Have you ever wondered what's in our blood? What it can tell about our well-being? What about the innovative technology used to unravel the mystery of what's in our blood? Hello, I'm Dean Whiting, and this is It's in Our Blood, the podcast series that explores the critical role technology plays in the pathology laboratory, in hospitals, and in the community setting. Welcome to the final part of our special series of podcasts highlighting pathology technology, disruptors past and future. Where we pick up here, we're still looking at solutions, but the panel and the audience have just seen a short video, and we start by asking some questions of one of the participants in that video. Enjoy. And I'm very happy to introduce Mr. Chris Williams, who was featured in that little piece there. And Chris, welcome and thank you very much for joining us. I just wanted to know if you could tell us a little more about your experiences, particularly the benefits in your case of testing with this new technology.
Oh, well, certainly for me, the benefits were getting the right treatment done in a very rapid amount of time. So it decreased ultimately the pill burden of the number of antibiotics that I needed to use in order to treat this.
Mm-hmm. Oh, wonderful. Can you tell us, your role you're also a healthcare advocate, and can you tell us a little bit more about that role and what that means?
Yeah, so I'm the co-founder of PrEP for Change, which is Australia's largest online community for people using PrEP or pre-exposure prophylaxis as a highly effective HIV prevention strategy that combines medicine with routine STI and HIV testing. So my role is very much around supporting people at risk of acquiring HIV and also providing information on developments in the field, including new diagnostics and testing developments.
Yeah, and you and I have discussed this a little bit, but I'd like you to expand. I've got this little bugbear that I think providing the right technology at the right time can change behaviours, can change the way people look at their own healthcare. So as an advocate, what are you seeing in, say, a cohort that you interact with when you do have a technology that is very successful?
Well, the behaviour change thing is obviously a hot topic in the space that I'm involved in.
Yeah.
Certainly what we see in terms of the most concerning end of the spectrum for behaviour change right now is we have in our annual surveillance reports, reports of decreasing condom use, or consistent condom use among key populations. So that is also then combined with a rise in resistant gonorrhea as well. And in addition to that, we have also new evidence to suggest that saliva is also a key transmission for gonorrhea. So we don't really use condoms for kissing, so we definitely need new technology interventions to solve this problem.
It's a new business idea for everybody.
So fundamentally that's the kind of the rough end of the spectrum, I think, in terms of behaviour change. But what we see as a result of interventions such as PrEP is how it has really empowered the community to start looking after their sexual health, and they're very much in a space where they want to opt in to proactively showing up for testing. Now, the effect of that is not just wanting to or having to show up for testing because they need to, it's showing up for testing because they want to. They want to look after themselves and their communities.
Yeah. We actually see a very similar analogue in Aboriginal medical services as well, where hemoglobin A1C is offered. That the communities take much more interest and responsibility for their own outcomes. It comes from within. So it's a very important part of this. What kinds of technology developments do you see as maybe having more positive impact on healthcare outcomes, especially in the cohort that you look after? I'm thinking, we've discussed this a little bit, things like self-testing, maybe self-collection, that sort of stuff. So what do you see as being important?
Those in particular, self-collection, self-testing, absolutely critical. Certainly when you're working with sexuality diverse, trans and gender diverse communities and culturally and linguistically diverse communities, there are a multitude of barriers that prevent somebody from showing up and accessing healthcare services. So the ability to run tests that are going to be effective with dignity and with privacy are critical to improving the health outcomes of those vulnerable populations.
No, that's very good. Thank you very much, Chris, and thanks for coming along. We really appreciate it. I guess the proposition here is that technology has the chance to change the paradigm in many, many ways of the way that healthcare is delivered. Changes potentially patient behaviours to take more responsibility and take more ownership of their healthcare outcomes. So in the face of potentially substantial increases in demand for healthcare, heavily dependent on pathology testing, I think our technology if we can clearly deliver the outcomes required, I think we have a huge role to play in healthcare of the future. It's highly likely that developing technologies will not only meet the demand, but it'll be the catalyst for the change that we need to deliver. And Frank's already started talking about some of those changes, and so has Colin. And it's highly likely that we'll start to move more towards screening and prevention, to early detection, to prognosis and management, and accessibility in the regional and remote areas especially, and of patients taking greater ownership of their own healthcare outcomes. So, Coleman, recently you've been involved in evaluating the benefits to the patient and the healthcare economy for funding hemoglobin A1C as a monitoring test for diabetes in the community setting. Can you summarise some of the benefits that you discovered from that work?
HbA1c is really the crux of the issue. It's sort of like what we're all here to discuss today. I think just stepping back a sec, like what you see in the environment out there is like this explosion in startups and health techs and who's seen like incubators everywhere and things like this and all this kind of great stuff happening. Malcolm Turnbull used to talk about innovation and these sort of things, and I think people have taken that on board, and what we're seeing is a lot of companies sort of spinning out of that with these great potential solutions. But what we have is I think a system at the moment that's kind of inflexible to deal with some of that innovation that's coming through, and is not really rewarding that innovation because the kind of framework we have in place is not set up at the moment to do that. And HbA1c is really, I think, right at the pointy end of this. The actual trial that whole application is based on is from 2008. It was actually a government-funded trial, and it showed that patients that received the point-of-care test actually managed their HbA1c a bit better over time. And so that has led into a number of evaluations by the committee, which is all by the MSAT committee, which is all in the public domain. But I guess in terms of what benefits you can evaluate from that, it's a classic example of we have our framework, and we need to stick to things like GP visits that are saved because you don't need to go back for the result. You can get the result then and there. You stick to the kind of costs associated with delivering the test, the test and the comparator. But you can't sort of consider things like patient preference, which is pretty straightforward, fairly obvious. It's a no-brainer. You can't consider things like productivity and efficiency and transport costs and just broader benefits for the economy. And so I think it's really a good example of kind of where we're at right now. This application, it's a bit kind of stuck in that architecture that's looking back a bit, and that's probably the challenge moving forward, is kind of how do we reward innovation whilst keeping a reasonable standards of evidence and sort of economics in place.
Yeah, I think that actually hits it flush on the head, as they say. Megan, I didn't have a question specifically for you on this part, but it strikes me that I should give you the right of reply there. So what? Yeah,
MSAC was actually positively minded towards, I think, hemoglobin A1C testing in not the diagnostic setting, but in the monitoring setting.
Yeah.
But there are implementation challenges around that. There are assessment challenges, and then there are implementation challenges. So one of them, for instance, is I've talked already about how we have a very high quality system. That quality system is delivered through MPAC's framework and then through laboratories, and there's a cost associated with that. And it's hard to, in a GP model where a GP so there's GP testing, obviously. Mm-hmm. The cost, so we want to ensure that GP testing is of a similar quality. So I know that NPAC, for instance, is reviewing the standards around hemoglobin A1C testing, and we would think that we should have, you know, a national standard around that. We shouldn't have different standards for general practice testing as we would for laboratory testing in that space, for instance. So, so that's one of the implementation issues, is ensuring that that's brought together. And similarly, the pricing of the test needs to take account of that, and clearly it can be done more efficiently, both taking into account the direct cost of testing, but also the cost of the quality provision of care and QA can be done much more efficiently by laboratories. Sometimes I kind of think, when I've seen this application come through MSAC a number of times, I'm a bit surprised that there hasn't been, approaches to it whereby point of care testing is actually done by pathologists in collection centres. Thinking about it, many patients, large volumes of patients, have their pathology testing or pathology sampling in a centre that's co-located with their general practice.
Yeah.
But that has never seemed to have been part of the discussion, is why doesn't the market meet, pathology laboratories meet that demand in different ways?
It's a very good question to ask the private pathology, and maybe public pathology. Maybe Scott, you've got an answer.
I know it has been looked at in a number of centres. One of the things that has been a barrier is the requirement for that to be an accredited facility and go through the whole process of accreditation as a laboratory. And there's a whole, and Mukesh, you mentioned that before about the regulatory framework around having a laboratory set up.
Yeah.
So I think it's a great idea. I'd love to see it done, but we've got a fairly restrictive regulatory framework which discourages that at the moment.
Yeah, that's right. And Mukesh, I was going to ask you exactly that question. From your perspective as a GP, what are some of the, is more extensive point of care testing a realistic expectation? Does the business case stack up for you, and what are some of the barriers?
Yeah, look, I have been battling with the provision of point of care testing in general practice since 1993 or 4. It's nothing that's been new, and the barriers we've heard of just now, unfortunately, are very pervasive. I mean, we know that this technology is out there and it works and it's accurate. We've gone through our accreditation process, a benchmarking process to make sure that the blood taken in the point of care test matches what's done in the laboratory, and that there is no differential of any significance. All the NATA accreditation standards that you have to do to make sure that you do that. And then once you pass that, there's yet another hurdle, and you pass that, and then you just think you got through there, and they put another one in, which to me, and I'm not a pathologist, so that's nonsensical, but I'm a GP, and I have a Royal College that actually works with the other Royal College, and they do come across and have a collective view on this. And it's not reasonable to expect a GP doing point of care testing to be accredited fully RSCPA fellow. And nor is it necessary when you're doing that sort of thing. A woman can go to a pathology, to a chemist and do a HbA1c, a beta-HCG. I remember when they first came out in emergency departments for ectopics, and you had to do it was called a ramp or something. Remember those? That was like a miracle. It suddenly started happening. So these things have changed. So we've got to move with the times. When I was part of the Health Hospital Reform Commission, which reported in 2009, by the way, folks, that's like a long time ago, and nothing's really come out of that because some really good ideas. And the medtech stuff, I work with a group called the Medtech Actuator, and there's something called the Medtech's Got Talent that's coming out very soon, and it's really about bringing through new technology, which you guys are going to get lots of stuff to deal with, I guess, when they reach the pointy end of their work. But I think it's about getting with a program that things are going to change. We've got to make sure they're safe, absolutely, accessible, absolutely, but we've got to make sure that we've actually got use of what's out there and make sure that it's, and I've used this in the technology and the IT side about being useful, usable, and be useful and have usefulness. So they're the things that have to be important if we're going to do these things. But we've got to do that. Is it a proposal today? In my practice of 18 GPs, and I don't have a full cohort saying they want to do this, because all they can see is a cost in doing this and not a benefit. And that's why the use case has to be made for how we use it. and then make the case for that being useful as an adjunct, because we're not going to be a full testing laboratory. But there are very useful tests available that have been available even to pharmacists in various trials to try and do, which would not been available in general practice. And I think that this is something that I know that the very senior members in the government today think is a great idea. The question is how to implement it and get the benefits without the downsides. And I think that is about potentially a good idea, having point of care testing in the collection centre itself, sure. But when they're not open, actually having them in a practice is useful. I know they do it in emergency departments for troponins and so on, and they're all very useful. So, it's not a yes or no. There is a gradation of what is useful and when it's useful, but we shouldn't be shutting the door on these things in these settings where there is a college standard and a NATA standard already adhered to and set and met.
Is it, I mean, this is a question without notice. The GPs have their own quality framework and their own assessing and auditing setup as well.
Well, my view very much would be that the expertise and the experience lies in the pathology laboratories with the pathologists. Mm-hmm. Now, that doesn't mean we couldn't work with the GPs, and that's probably the model that hasn't been explored sufficiently. And in fact, I'm just thinking about how we manage point-of-care testing around the hospital network. We have nurses managing the instruments, nurses doing the testing, but we actually manage their competency and their quality control systems. Mm. So a relationship between the pathologist's expertise and the GP, I think I doubt it's been done, but I don't see any reason why it couldn't be done.
Well, there's an example already with the QAMS project, which is run, out of Flinders University, which does exactly what you suggested. Has the training overlay, the quality assessment overlay, and as far as I know, it doesn't go through the College of GPs or the College of Pathologists. Yeah.
So the reason this is worth pursuing is that Theranos almost happened.
Yes.
And with all due respects, it was the pathologists who picked it up. But where I'll head from there is to a positive side, is that that put a pressure on a lot of the developers. And so microfluidic testing is now reaching its maturity in the trade displays in the US. Mm. It's coming. Mm. And so there'll be an awful lot of testing available in the GP's practices. So we need to think about a model for helping with this. It's coming. I think let's work out how to do it.
Oh, wonderful. This ends at the special editions of our podcast with the highlights from Pathology Technologies Disruptors Past and Future. Our regular podcasts will commence again next time around. Thank you for listening to this edition of It's in Our Blood. Look out for further topics in this series or go to pathologytechnology.org.au. This podcast is produced by London Agency, Melbourne, Australia.